I agree that diuretics have a role in CKD, but it's the phrase first line is debated. But first, do diuretics are effective as antihypertensive in CKD, and do they improve hard outcomes in CKD? Dr. Alaa mentioned the ALL-HAD trial and the advanced trial, but actually at baseline, most of these patients did not have CKD. Now, this is the KDIGO CKD guidelines, which were released in April. They set the first-line drug therapy for most patients with CKD as being SGLT2 inhibitors and aiming for low blood pressure together, ideally with maximally tolerated RAS inhibitors, plus statins for cardiovascular protection. And they add diuretics, but as second, third, or fourth line treatment. So non-steroidal MRA, finerenone, as Dr. Alaa mentioned, it is recommended in patients with diabetes if they have to reduce cardiovascular risk and to reduce proteinuria. Second line after RAS inhibitors in non-diabetics would be either calcium channel blocker and or diuretics. And if the three fail, then steroidal MRAs are indicated. But actually, diuretics have an important role in hypertension in CKD, as most patients have salt-sensitive hypertension and eventually need low-salt diet and diuretics. Because of the kidney disease, there is salt and water retention and volume expansion. And actually, this reduces the RAS activation, which may impair the action of RAS inhibitors. And that's why, as Dr. Alaa mentioned, there is improvement in RAS inhibition after initiation of steroids together with it. But diuretics are either high efficacy, which are the loop diuretics, and they can be used at any GFR, but classically in most papers they are only used for volume overload. Moderate efficacy diuretics, thiazides and thiazide diuretics, they are mainly used as antihypertensive in fixed dose combinations. They're not really available as single drug, but they are classically indicated for patients with a GFR of more than 30, although there is some recent evidence that thiazide-related diuretics like metolazone, chlorothalidone, and indapamide may be effective in lower GFR. Low efficacy diuretics include MRAs. They have proven cardiovascular and antiproteinuric effect, but in CKD there is the risk of hyperkalemia, the risk of AKI, and they are usually avoided in GFR. It's variable in various sources, but for example, finerenone, it's indicated if the GFR is above 20, some say above 30. But why are thiazides or the action of thiazides so questionable in CKD? In CKD, there is decreased absorption of thiazides. Thiazides are protein bound, and in proteinuria there may be low albumin, giving a short half-life. Chlorothalidone, indapamide, and metolazone are bound to erythrocyte carbonic anhydrase, but in anemia of CKD, their half-life may shorten. And most importantly, for them to act, they have to be excreted in urine by proximal tubular secretion, and reduced delivery to the tubular lumen may reduce their natriuretic effect. So their effect in CKD, and especially in advanced CKD, is questionable. This has been challenged by the CLIC trial, which included patients with CKD stage 4 and resistant hypertension who were randomized to either receive chlorothalidone or placebo, but they were resistant and they had a mean number of 3.4 medications. And actually, it showed that it's even in stage 4s, it is effective. It reduced blood pressure by 11 millimeter mercury. It reduced albuminuria, but especially with diuretic, it increased the risk of elevating the creatinine by 9 times. But this elevation was in most cases reversible on discontinuation, saying it may be a hemodynamic effect rather than a nephrotoxic effect. Although it's commonly cited, it's relatively small number, it's short follow-up, only 12 weeks, and the patients were taking multiple medications, so we cannot apply this to patients as first line, and it did not look at hard endpoints. How about loop diuretics? Actually, they are relatively of short durations. That's why they have been limited for their use as high antihypertensives. They are more commonly used to reduce volume, and there are very few clinical studies that examine their blood pressure lowering efficacy, and no data on the clinical outcome of loop diuretics. However, this is an interesting trial that compared hydrochlorothiazide with furosemide in stage 4 or 5 CKD and found that they both had similar blood pressure lowering effect. Do diuretics have antiproteinuric or renoprotective effect? As we said, mineralocorticoid receptor antagonists do have it, but loop diuretics, there is no studies, and in thiazides, they were effective mainly when combined with RAS inhibitors, but most papers were short-term, and this benefit may be because of reducing sodium load, which inhibits the antiproteinuric effect of RAS inhibitors, improving blood pressure, or it may have a hemodynamic effect similar to SGLT2 inhibitors, but it has not been proven so far. The second question was, are diuretics safe in CKD? Actually, in the CLIC trial, there were side effects in 91% in the chlorthalidone, but 86% in the placebo, and they were more frequent with loop diuretics. And generally, adverse events of diuretics are more common in CKD. They include electrolyte imbalance, but also hypovolemia, AKI, interstitial nephritis, hyperkalemia when it comes to MRAs. So actually, they may be of risk in patients with CKD. There is also the concern that diuretics would lead to increase the creatinine and lead to CKD progression and end-stage renal disease. Most clinical studies evaluated only short-term and either in combination with RAS inhibitors, but not alone. And there was observed elevation in renal function, which may be direct injury, but also, as we said, may be beneficial hemodynamic effect, maybe hemoconcentration because of the volume depletion, or maybe because patients who require diuretics have poor underlying clinical condition. As was hinted at by this retrospective cohort, which included patients with GFR 15 to 59, prescribed either loop or thiazide, although there was increased crude rate of end-stage renal disease and the composite renal outcome, but after causal inference, there was no association with CKD progression or end-stage, again hinting that maybe patients with volume overload and poorer cardiac and kidney condition eventually require diuretics. There is also a concern of the concomitant use of diuretics and SGLT2 inhibitors because both are diuretics. Although in most studies, actually SGLT2 inhibitors were associated with reduced risk of AKI, the KDIGO actually recommend that before prescribing SGLT2 inhibitors, we assess the volume depletion risk and the concurrent diuretics, the volume status of the patient, and if the patient is towards dehydration, if he is dry and there is risk of AKI, we can reduce diuretics together with SGLT2 inhibitors. So are they effective and safe as first-line therapy? I don't think they are effective as first-line therapy, but they are probably a good second or third-line therapy, and they should be given with precautions. Mainly, we should introduce diuretics gradually with cautious dose escalation. We should monitor blood pressure, serum electrolytes, and kidney function, similar to how we monitor in RAS inhibitors. And chlorthalidone may be a good alternative to spironolactone in resistant hypertension, and long-term studies are needed to examine the role of diuretics in CKD. Thank you.